Thank you very much for that kind introduction, and thank you for including me in this program. It was a tremendous talk that I'm following Dr. Valdez. As suggested, I'm going to cover really the role of endoscopy in the management of anterior skull-base meningiomas. As you just heard, there really is a spectrum of meningiomas that we cover in the anterior skull base in terms of anatomic origin. And generally, when I think of anterior skull-base meningiomas, I think of three broad categories. You have the olfactory groove meningiomas, the planosphenoidale meningiomas, and the tuberculous sphenoidale meningiomas. And the distinction between these three different categories really stems from the relationship between the tumor and the olfactory nerves and between the tumor and the optic nerves. And really, I think it's important to distinguish really the tuberculum sella meningiomas from the planum and olfactory groove meningiomas, because the tuberculum sphenoidale meningiomas, given their origin along the limbus sphenoidale, they tend to push the optic nerves out and laterally, and tend to be much more adherent to the optic apparatus versus the planum and olfactory groove meningiomas. While these may present with larger sizes and may appear to compress the optic apparatus, there's usually a thin arachnoidal plane that separates the inferior pole of the tumor away from the optic apparatus. And so the visual outcomes tend to be pretty good. So I'm really going to focus on the role of endoscopy in the management of tuberculum sella meningiomas, because this is really an area where there's a need to improve outcomes. So the challenge with managing these tuberculum sella meningiomas stems from the spectrum across which they present. You can certainly have these small asymptomatic but progressive tuberculum sella meningiomas. Then you can have these tuberculum sella meningiomas that compress the optic chiasm, but don't have any major vessel encasement. And then you can have these tuberculum sella meningiomas that compress the chiasm, invade into both optic canals, and have major vascular encasement of the supraclinoid ICA and the anterocerebral artery system. So even before getting into the optimal surgical strategies and the role of endoscopy, I think it's important to first delineate the expectations of treatment in general, really the outcomes we've seen with transcranial approaches, and then where endoscopy comes in to help improve overall outcomes. So this is an example of a patient presenting with visual decline in both eyes and with optical coherence tomography measurements demonstrating decreased retinal fiber layer measurements. And certainly when you see a patient in clinic like this, there's a patient who needs treatment, and really what the goals of treatment are first off to achieve a gross total resection, because we know that achieving a gross total resection has a significant impact on long-term tumor outcomes. The other goal of treatment is certainly stability or improvement of their visual function, preservation of their endocrine function, given that the pituitary gland is often displaced posteriorly behind these tumors, and of course, preservation of neurologic function. And ideally, you want to get a post-operative scan like this, regardless of whether you use an open transcranial approach or an endoscopic approach, and with visual outcomes that have improved in comparison to preoperatively. So the question is really what factors predict extent of resection, agnostic to surgical approach. So certainly when I see patients in clinic, the discussion really revolves around achieving a gross total resection. And as we know, based on the data, even in the best of hands, a gross total resection is only achievable in between 86 and 92% of patients. And so really, who are the patients where a gross total resection may not be achievable? And there was this great paper published in 2018, a multi-institutional study looking at tuberculum sella meningiomas and identifying anatomic factors that correlate with extent of resection. And what we know is that there's sort of three broad categories that predict patients that are less likely to get a gross total resection. So first off is tumor size. Generally tumors that are greater than 17 millimeters, which correlates to the distance, interoptic distance, these tumors are less likely to achieve a gross total resection theoretically. Also, patients that have either unilateral or bilateral optic canal encasement, and typically if that extension goes beyond 3 millimeters, are less likely to achieve a gross total resection. And then also vascular encasement, 180-degree involvement of either the supraclinoid ICA or the anterocerebral artery system. Now, certainly when you see a patient with all these risk factors, the goal is still to achieve a gross total resection. But I think it's important to keep these factors in mind when you ultimately decide between an endoscopic versus an open approach. In terms of looking at predictors of visual outcomes, in general, agnostic to whether a transcranial or endoscopic approach has been done, when we look in the literature, for patients presenting with visual decline secondary to tuberculum sella meningioma, about 68 to 74% of patients will and should experience visual improvement after surgery. About 8 to 12% of patients do experience visual decline. And I think there are numerous factors related to this. Now, all sorts of work has been done to help identify a clinical metrics to predict which patients will do better post-operatively with regards to visual outcomes. Certainly looking at the simplest form of an ophthalmologic evaluation, the degree of impairment on visual acuity and visual fields, to more sophisticated means looking at optical coherence tomography and looking at retinal nerve fiber layer has been incorporated into clinical decision-making tools. But from the surgical standpoint, there are some key maneuvers that need to be done in order to ensure optimal visual outcomes. And you certainly heard from Dr. Valdez's talk about the importance of optic canal decompression and anterior clinoidectomy. Now, ultimately, the cause of visual decline secondary to these meningiomas is both mechanical compression and vascular encasement also. These tuberculum cell meningiomas will certainly have varying degrees of compression of the cisternal and the intracanalicular components of the optic nerve. And with the use of high resolution imaging, there are several studies out there demonstrating that up to 67% of patients will have tumor extension into one or both optic canals. And so what this means is that in taking any patient to the operating room with a tuberculum cell meningioma, you need to be able to and willing to decompress and open up both optic canals in order to ensure those optimal visual outcomes. And certainly what I use in my own practice, and I think many of us do, is use high resolution preoperative imaging to really help determine the location of the optic nerves relative to the tumor and the degree of extension into the optic canals to help ensure adequate preoperative planning. And then there are also the vascular considerations. We know from extensive anatomic work done that the vascular perfusion to the optic chiasm and the cisternal segments of the optic nerves comes from the superior hypophyseal arteries. And then when we look at the intracanalicular and orbital segments of the optic nerves, the ophthalmic arteries are key. And so with any resection of a tuberculum cell meningioma, these fine vascular perforators must be preserved in order to ensure adequate postoperative visual outcomes. Now, there's no doubt that transcranial approaches or the traditional craniotomy has made an impact in the outcomes for patients with tuberculum cell meningiomas. So take an example such as this patient here with a partially calcified tuberculum cell meningioma with bilateral extension into the optic canals, and simply the ACAs are displaced posteriorly. A patient like this does well, whether it's via a pterional craniotomy or a modified frontotemporal craniotomy with an orbital osteotomy. We know that we can do an extradural decompression of the left optic canal and anterior clinoidectomy, then internally debulk the tumor. And then after decompressing the thinned out optic nerves, you get a nice view like this with the left optic nerve, the right optic nerve, the chiasm, and the pituitary infundibulum preserved postoperatively with the gross total resection. When we look at outcomes from transcranial approaches or the traditional open skull-based approaches for tuberculum cell meningiomas, looking at extent of resection, the extent of resection rates reported traditionally were between 86 and 100%. What I'll make a comment about this 100% extent of resection rate from Professor Yazago is that this was in the era before the use of postoperative MRI scans and even CT scans, and was based on intraoperative surgeon assessment. But otherwise, I think when you look in the modern era with the use of transcranial approaches, the extent of gross total resection has been reported in between 85 and mid 90% of patients. When we look at visual outcomes after a craniotomy, what we find is that about 10 to 12% of patients have been reported to experience some sort of visual worsening after transcranial approaches for tuberculum cell meningiomas. And what I'll say is this is really where endoscopy has been highlighted as perhaps as a means to improve visual outcomes for these patients, and I'll discuss that a bit further. And then we look at the nature of the complications encountered with transcranial approaches. What was reported is that up to 10% of patients had some sort of vascular injury, whether it was a postoperative hemorrhage or infarction secondary to vascular injury. And CSF leak rates reported anywhere between 1 and 7% of patients undergoing a transcranial approach. So I think, certainly with the desire to improve extent of resection, improve visual outcomes, and reduce complication rates, this is really where endoscopy has really entered into our toolbox in the management of tuberculum cell meningiomas. The endoscopic endonasal approaches were really initially popularized for the management of pituitary cellular and paracellular pathology. And as instrumentation, techniques, and understanding have improved, as we all know, endoscopy has been applied to the management of other skull-based lesions with the thought that there is much less manipulation of the cranial nerves, much less brain manipulation, and perhaps improved access to the target site. So take an example of this patient. This is a patient with a tuberculum cell meningioma, optic nerves displaced out laterally, tumor extension into the right optic canal. I think certainly in a majority of practices, a patient like this would undergo a craniotomy. But this patient came and really wanted an endoscopic endonasal approach. And one of the traditional concerns with the management of a lesion like this by an endoscopic endonasal approach was the limited ability to deal with tumor extension to the optic canal. But certainly the techniques have improved, and here's a view intraoperatively of this resection, working through the nasal cavity, using self-irrigating diamond drill bits. Essentially a transplanum, transtubercular approach is being done. Here you can see the right optic canal being decompressed, bilateral miloclinoidectomies are being performed. And then ultimately, after the bony resection is done, just like any other microsurgical approach, the tumor is devascularized. And then ultimately, there's some debulking that's performed in order to shrink the tumor away from the surrounding structures. And I'll fast forward this for save some time. Here, we're using an ultrasonic aspirator, the same tool that we would use via traditional craniotomy, using an endonasal tip to debulk the tumor. After a significant amount of debulking, the lateral capsule of the tumor is dissected away from the carotid artery. The attachment of the tumor to the superior inner cavernous sinus is attached, and then the dural incision is carried up superiorly. You'll ultimately see a hint of the left optic nerve here displaced out laterally. And then after sort of mobilizing that left lateral component of the tumor, the superior pole of the tumor is dissected away from the overlying arachnoid. The dura of the right optic canal is opened in order to further decompress that. And then here you can see the superior hypophyseal artery branches that are preserved, a view of the entire optic apparatus, both carotid arteries in view in the pituitary infundibulum. Now, of course, the challenge with the endonasal approach is not necessarily the resection, but also the reconstruction to reduce the risk of a postoperative CSF leak rate. And we know that in general, there's several tissue layers that prevent a CSF leak in any patient. And essentially those layers are reconstructed in multi-layer closure, but what's key is having a good vascularized flap. And typically most practices will use nasal septal flaps that are rotated to cover the defect and it's secured into place. And that dramatically has reduced the risk of a CSF leak rate postoperatively. And so here you can see the preoperative scans here on the left and the postoperative scans here on the right showing complete resection. Now, to further highlight the ability of endonasal approaches to highlight optic canal extension, this is a patient that I treated several years ago who presented with pretty rapid visual decline in the left eye and an MRI scan showing a really small meningioma in the optic canal. Now, this patient was initially told that she had an optic nerve sheath meningioma, and as I think many hospitals would do for an optic nerve sheath meningioma is that they would typically radiate it. And so she came to see us for a second opinion, and this looked like a very focal meningioma within the optic canal that was not a true optic nerve sheath meningioma. And so what I offered in this patient was an endoscopic endonasal approach. So again, working through the nasal cavity, opening up the left optic nerve and decompressing the supraorbital fissure. And ultimately what we'll have is a cavernous sinus, the optic canal in view. Here's a carotid artery just distal to the drill, a Doppler on the carotid artery underneath the optic canal, the dura of the optic canal being opened up. And here's a small meningioma along the inferior surface of the optic nerve that's being dissected off the optic nerve now. And then ultimately we're able to trim and completely resect the base of this tumor to get a Simpson 1 resection and a grossal resection with the decompression of the optic nerve. And you have a nice healthy nerve looking at the end. And so this is a patient who initially was recommended radiation, benefited from surgery with complete resolution of her visual symptoms. So looking at the reported endonasal outcomes, what we find in the literature is the rates of resection varying between 67 and 92%. Visual outcomes, really a much lower risk of worsening of visual outcomes relative to the transcranial approaches. And then the complication rates, the nature of the complications seen with the endonasal approaches is different than the transcranial approaches. Lower risk of vascular injury, but a higher risk of CSF leak rate. Now, certainly in looking at this reported data, the traditional criticism of the endonasal literature, and rightfully so, is that perhaps the outcomes are better with the endonasal approaches because the smaller tumors are being taken to the operating room for an endonasal approach, instead of those being selected for by a transcranial approach. And so there really is a need to compare series in a matched fashion. And so to the credit of these authors in South Korea, what they did was did a retrospective matched cohort study where they matched 84 patients with tuberculum cell meningiomas who underwent an endoscopic and nasal approach versus 94 patients with tuberculum cell meningiomas that underwent resection by a traditional transcranial craniotomy. And so these are patients that underwent surgery for tumors that the authors felt were amenable to both open and endoscopic approaches. And the cohorts were matched for preoperative visual dysfunction, tumor size, extent, and optic canal involvement. And the outcomes that they assessed were extent of resection and visual impairment score. And what the authors found is that between the endoscopic, endonasal, and transcranial approaches, there was no significant difference in gross total resection rates. But what they found was that the visual outcomes were slightly worse in those patients undergoing transcranial approach, and specifically those patients that had optic canal involvement. And so really the take-home point of this paper is that first off, in terms of endoscopic, quote unquote, versus open, really it's dependent on the surgeon and their abilities. But that the endoscopic approaches perhaps have a slight advantage in terms of visual outcomes when we look at those tuberculum cell meningiomas that have optic canal extension. So, the way I look at this in my own practice, certainly my personal practice is split 50-50 between the endoscopic, endonasal, and the transcranial approaches. And when I'm evaluating patients in clinic and trying to determine whether or not to offer which surgical approach, what I look for is particular patterns of tumor extension. So if there's disease extending lateral to the anterior clinoid, disease extending superior lateral to the optic nerve, vascular encasement, or disease extending lateral to the carotid artery, then I'm much more inclined to offer a transcranial approach. Otherwise, in the other scenarios, I think the endoscopic endonasal approaches have higher rates of visual improvement. So to summarize, with tuberculum cell meningiomas relative to the olfactory and plana meningiomas, I think the tuberculum cell meningiomas have unique considerations with regards to preservation of visual function related to the anatomic location of these tumors. Surgery is certainly considered the gold standard when we look at long-term tumor control rates and visual outcomes, and the expectations of surgery are very clear, and those expectations really guide whether an open or endoscopic approach should be used. And certainly there's a need for more studies to determine really in scenarios where there's a clinical equipoise, whether open versus endoscopic approaches are superior. Once again, thank you very much for including me in this session.